Okay, this is the second part of the reading session. We are going to continue reading about the lower abdominal and pelvic pain in women. This topic is dysmenorrhea. Dysmenorrhea is simply mentioned as painful periods. It may be functional in the absence of any organic diseases, which is known as primary dysmenorrhea. Primary dysmenorrhea is common in adolescent women. In comparison, secondary dysmenorrhea is painful menstruation that is due to a pelvic pathology. So it's very important in a clinical case scenario to differentiate primary from secondary dysmenorrhea. We'll talk further about primary dysmenorrhea or what is called functional dysmenorrhea. This is the menstrual pain associated with ovular cycles without any pathological findings. The pain usually commences within 1 to 2 years after the menarche and becomes less severe with age. It affects about 50% of menstruating women and up to 95% of adolescents. The clinical features are the low midline abdominal pain, which radiates to back or thighs. Then it varies from a dull dragging to a severe cramping pain. Maximum pain is at the beginning of the period and may commence up to 12 hours before menses appears. Usually lasts 24 hours but may persist for about 2 to 3 days. May be associated with nausea, vomiting, headache, syncope, or flushing. There are no abnormal findings on examination. So this diagram illustrates lower abdominal pain that may radiate to the buttocks or the upper thighs. How do we manage? The full explanation and appropriate reassurance is very important, and promote healthy lifestyle, regular exercise, avoid smoking and excessive alcohol. Recommend relaxation techniques such as yoga. Avoid exposure to extreme cold. Place a hot water bottle over the painful area. Those are the non-pharmacological management methods. The pharmacological methods include simple analgesics like aspirin or paracetamol, non-steroidal anti-inflammatory drugs like naproxen 500 milligram, and then 250 milligram every 6 to 8 hours, or ibuprofen 200 to 400 milligram 3 times a day, and commence at first suggestion of pain in the first 3 days of the period. Then if it's not responding to these analgesics, we can offer combined oral contraceptive pill to the patient. If not helped by these treatments, then further investigations are required for a possible secondary cause. Then let's move on discussing secondary dysmenorrhea. Secondary dysmenorrhea is menstrual pain for which an organic cause can be found. The pain begins as a dull pelvic ache, usually occurs 3 to 4 days before the menstruation and becomes more severe during the period of menstruation. Commonest causes include endometriosis, adenomyosis, pelvic inflammatory disease, submucous myoma, intrauterine polyp, or pelvic adhesions. Investigations include ultrasound and laparoscopy. Management involves the treating the cause. Consider medical management for possible endometriosis. Then let's move on discussing about endometriosis. Endometriosis is a chronic inflammatory gynecological condition caused by hormone-dependent growth of endometrial-like tissue outside of the uterus, usually on the peritoneum and ovaries. Deposits may be superficial or infiltrating, causing hemorrhage, adhesions, and ultimately dense scar tissue changes. Endometriosis infiltrating the myometrium is referred to as adenomyosis. Endometriosis is the most common single cause of chronic pelvic pain in women. The average time to diagnose is 6 to 6.5 years. Patients experience varying degrees of symptoms according to the site and severity of the endometriosis deposits. The diagnosis may be masked by the combined oral contraceptive pill. Pregnancy is beneficial, but recurrence can follow. What are the clinical features of endometriosis? Incidence is 5 to 10%. Can occur from puberty to menopause, but the peak incidence occurs between 25 to 35 years of age. There can be a family history. If there's a first degree relative with endometriosis, there's a 3 to 10-fold increased risk. Dysmenorrhea, gastrointestinal symptoms during menstruation like painful defecation, diarrhea, urinary symptoms like dysuria frequency. Pain may radiate to lower back, legs or rectum. Subfertility, dyspareunia, non-specific pelvic pain, heavy menstrual bleeding, premenstrual spotting, acute pain with rupture of endometrioma. So there's a diagnostic triad, dysmenorrhea, heavy menstrual bleeding, and dyspareunia suggest endometriosis. What are the possible signs? The uterus is usually fixed and retroverted. There can be tenderness and nodularity in the pouch of Douglas or rectovaginal septum, uterine enlargement and tenderness. Diagnosis. Consider endometriosis in any woman with painful period that do not respond to non-steroidal anti-inflammatory drugs and significantly interfere with daily functioning. The gold standard of diagnosis is by direct visual inspection at laparoscopy. Diagnostic laparoscopy is not always required, and a presumed clinical diagnosis may be appropriate. Transvaginal pelvic ultrasound may identify adenomyosis, ovarian endometrioma, or rectal endometriosis. But however, normal ultrasound scan findings do not exclude diagnosis of endometriosis. Then the treatment. We have to carefully explain the patient. The approach depends on the patient's age, impact, and the severity of symptoms and family planning. Options include analgesia, hormonal, and surgical treatments. Analgesics are the first line, non-steroidal anti-inflammatory drugs, paracetamol or combination can be given. Hormonal treatments include combined hormonal contraception, the oral contraceptive pill or vaginal ring. Consider extended or continuous use. Then progesterones, levonorgestrel releasing intrauterine devices like Mirena coil can be inserted 5-yearly or Dianogest 2 mg oral daily or northisterone 5 to 10 mg daily up to 10 mg twice a day. Medroxyprogesterone acetate or the intramuscular depot injections 150 micrograms every 12 weekly. Then GnRH analogs like groserelin 3.5 mg subcutaneous implant every 28 days or nafarelin 200 micrograms intranasally twice a day for up to 6 months. But this requires specialist advice. Hormonal therapy is often used post-surgery to prevent recurrences. The surgical options for treatment of endometriosis include laparoscopy, that is indicated for diagnosis, and excision or ablation of the disease, especially if there's associated infertility. General principle is the first go is the best go, as there is risk of scarring from repeated procedures. Recurrence of symptoms is common. Hysterectomy may be recommended as a final option of treatment. Many patients will develop chronic pelvic pain, which requires a multidimensional approach. Next is the pelvic adhesions. Pelvic adhesions may be the cause of pelvic pain, infertility, dysmenorrhea, and intestinal pain. They can be diagnosed and removed laparoscopically when the adhesions are well visualized and there are no intestinal loop firmly stuck together. Let's move on to a big topic, chronic or persistent pelvic pain. Chronic or persistent pelvic pain is defined as non-cyclical pelvic pain present for at least 6 months and that is severe enough to cause functional disability or require treatment. The 3 main important diagnostic criteria are the pain is non-cyclical, duration is more than 6 months, and it's severe enough to cause functional disability or to require treatment. The persistent pelvic pain is a challenging presentation which can be viewed as a complex neuromuscular psychosocial disorder. Multiple systems can be involved, including gynecological, urological, gastrointestinal, musculoskeletal, and psychological. There's a high incidence of associated mental illness, post-trauma, and post-traumatic stress disorder. It is important to identify and ensure adequate management of treatable causes. The common causes of chronic pelvic pain are listed as can be genital causes or non-genital causes. The genital causes are the endometriosis or adenomyosis, pelvic inflammatory disease, which causes chronic adhesions, ovarian pathology, prolapse, vulvodynia, chronic vulvovaginal candidiasis, pudendal neuralgia, and fibromyalgia, which is very rare. The non-genital causes include adhesions, inflammatory bowel disease, diverticular disease, irritable bowel syndrome, pelvic congestion syndrome, and urinary disorders like interstitial cystitis. Then features of chronic pelvic pain include that affects 15 to 25% of women, endometriosis causes 33%, and adhesions causes 24% of the incidence. Reasons for up to 40% of laparoscopies and 5% of hysterectomies. Possible symptoms include dysmenorrhea, cyclical aggravation of pain, dyspareunia, difficulty inserting tampons or menstrual cups, vulvovaginal irritation or pain, bladder symptoms may be frequency, dysuria, urgency, irritable bowel like bloating, alternating bowel habits, sensitivity to light touch in the lower abdominal or genital region, musculoskeletal involvement, which is pain with movement or prolonged positions, psychosocial difficulties like social withdrawal, hypervigilance to pain, and low self-confidence. Management of chronic pelvic pain. Like all chronic pain, a multidimensional approach is indicated. A reduction of pain with improved function and well-being may be more achievable than cure. A helpful approach is to address four components of persistent pelvic pain: the pelvic organ pain, pelvic muscle pain, central sensitization, and psychological sequelae. How do we address pelvic organ pain? By minimizing the number of periods if there's dysmenorrhea. We can use hormonal contraceptives and GnRH agonist. Hysterectomy is not considered a cure. Avoid repeated laparoscopies. Avoid bladder irritants like caffeine, acidic drinks, and stay hydrated. Treat symptoms of overactive bladder. Treat vulvovaginal irritation. Treat symptoms of irritable bowel. Next, the management of pelvic muscle pain. Keep active. Avoid aggravating activities. Pelvic physiotherapy. Botulinum toxin injection for severe cases. How to manage central sensitization? By patient education, exercise, relaxation strategies, optimization of sleep, neuropathic pain medications like amitriptyline, selective noradrenaline receptor inhibitors, and gabapentinoids. Then psychological sequelae, re-engagement with family, friends, and community, then psychological therapy. Next, move on to pudendal neuralgia. Pudendal neuralgia causes a burning or sharp pain in the saddle area, anywhere from the clitoris back the anal area, often when sitting. It may be uni or bilateral and may be associated with increased clitoral arousal. There is often associated bladder or bowel irritation. Causes include childbirth or trauma, injury to pelvic or perineal trauma, gynecological or colorectal surgery, cycling, excessive physical exercise, musculoskeletal issues, straining with bowel or bladder emptying. There's usually a combination of causes. Avoiding activities that compress the nerve, such as cycling, modify sexual practices to avoid pain, a U-shaped foam cushion with the front and center area cut out when sitting, a pelvic physiotherapy to relax, and or stretch the pelvic muscles and reduce pressure on pudendal nerve. Avoid straining with bowels or bladder. TENS machine, the trans-electrical nerve stimulation, the neuropathic pain medications, and interventional management, which include injections such as cortisone, hyaluronic acid, Botox, platelet-rich plasma. Pulsed radiofrequency treatment, pudendal nerve release surgery, implantable neuromodulation devices. And apart from all these things that we have discussed, we should know when we need to refer the patient for a more specialized opinion. Those include all cases of unexplained infertility, patients with suspected endometriosis not responding to analgesia or hormonal therapy, severe pelvic pain in pregnancy, pregnancy of unknown location, patients with positional dyspareunia, symptomatic or complex ovarian cyst, patients with complex or chronic pelvic pain. The practice tips mentioned are: think of endometriosis and ovarian cyst in any woman with low abdominal pain. In any woman whose normal activities are disturbed by dysmenorrhea, unrevealed or unrelieved by non-steroidal anti-inflammatory drugs, endometriosis should be suspected. After surgical emergencies have been excluded in a young woman with acute pelvic pain, consider pelvic inflammatory disease. A positive beta HCG plus an empty uterus and an adnexal mass are the classic diagnostic features of ectopic pregnancy. That's all mentioned in this chapter. Let's meet up again reading another chapter. Thank you for watching. See you.